Hello, and thank you so much for joining us for the Multiplex That Matters Considerations for Maximizing Impact of Multiplex Respiratory Assays webinar. My name is Jenny Scott, and I'm the Strategy Manager for Customer Experience here at Roche Diagnostics, and I'll be your host for today's webinar. I want to start with just a few housekeeping items prior to introducing you to our presenters. At this time, if you would please hover your mouse over the bottom of your screen to locate the control panel. We will not be using the raise hand feature during this webinar because we're unable to take you off of mute. We ask that all questions be submitted through the Q&A button. To submit your question, simply click on the Q&A button, then type your question into the comment box and click send. You may have to click ask question if you're using a phone or a tablet. Your questions will only be sent to our Roche panelists, but you're welcome to send them anonymously. As I mentioned, we'll do our very best to address all questions before the end of this presentation. At this time, I'd like to go ahead and introduce you to today's moderator, Dr. Tiffeny Smith, Scientific Partner, Infectious Diseases here at Roche Diagnostics.
Thank you, Jenny. And I have the honor of introducing our two experts today. The first is Dr. Nam Tran, Professor and Senior Director of Clinical Pathology at UC Davis Health and Director of both Pathology Biorepository and the new UC Davis Center for Diagnostic Innovation. And our second speaker today is Dr. Larissa May, Professor of Emergency Medicine and Director of Emergency Department Innovation and External Partnerships. These speakers will share their experiences in implementing multiplex respiratory PCR solutions within their health network and the impacts that they have seen from these diagnostic tests. Now, I would like to turn it over to Dr. Tran to begin the presentation.
Great, thank you, Tiffany. Great, so thank you for that wonderful introduction. I'm Nam Tran, so I'm at UC Davis, and I want to really get us started on our experience with multiplex testing throughout the pandemic and as well as leading into today. So some quick learning objectives. We're going to really understand the characteristics that differentiate various kinds of multiplex platforms that we have available. We're going to describe one institution, namely at UC Davis, considerations for implementation of multiplex testing algorithms, respiratory algorithms. And then we're going to summarize the laboratory and patient impact of our institution's implementation of these multiplex respiratory assays and summarize the challenges in patient access to these multiplex solutions and really kind of identify possible solutions to work around these challenges. Quick disclosures for me. I am a consultant for Roche Diagnostics and Roche Molecular Systems. UC Davis is a Roche Diagnostics Center of Excellence. I also consult for Radiometer and receive speaking honoraria for and travel support from Nova Biomedical and speaking honoraria for DiaSorin and Thermo Fisher. So diving into this complex world of respiratory testing, we now live in a time where we have highly multiplex platforms that could detect a large number of bacterial and viral pathogens. We have high throughput systems that currently have low multiplex capability, meaning that they can test one or two different and maybe three different types of organisms all at once, but test hundreds and possibly thousands of tests per day. And we now live in a world of a point of care, single or low multiplex pathogen form testing with these broad multiplex systems. And this, of course, created challenges both for a test utilization in relation to actual impact to patient care, but also the cost to the health system and the patient, right? These multiplex kits are not cheap. So we released education years ago. This is an example of our laboratory best practice blog that UC Davis publishes probably about every few months, every quarter or so. And in this case, we asked the question, should we multiplex or not? And especially during influenza season. And this education included an algorithm that was implemented and seems to have helped us throughout pre-pandemic and post-pandemic era, that for adult patients in particular with respiratory symptoms, inpatients, ED patients that are going to be admitted, and those that are immune compromised from an outpatient setting, yes, you can do multiplex PCR testing for respiratory infectious diseases. However, low-risk outpatients, ED patients not being admitted, and especially during flu season, and when a flu result will help you dictate management, run on our point-of-care molecular platform that tests for flu, right? So it is very pragmatic, and it seems to have been accepted pretty well at our institution. The COVID-19 pandemic changed a lot of things, of course. We thought we were ready for it with H1N1. Ebola made us overconfident, but we also then realized how under our poor infrastructure, our public health system in the United States. This resulted in a rapid surge in resources for a lot of laboratories, especially in the molecular and infectious disease domains. And now post-pandemic, we have to ask ourselves, what do we do with all these technologies, and revisiting the topic of utilization for these technologies we have. Like many of you in the audience, we were watching with some degree of interest in December of 2019 about SARS-CoV-2. The lockdown of Wuhan in January of 2020 was definitely concerning. But at UC Davis, we were either fortunate or unfortunate to be the first institution in the US to encounter the first known community-acquired case of SARS-CoV-2. And I say it's fortunate from the context that it put us on a warpath much earlier in the process and rapidly accelerated our means to bring up testing. In fact, we brought up our first COVID test in about 18 days. This was an open plate PCR system, like many of you. We all probably have the same instrument. But we then scaled to increased volume just to be able to deal with all the numbers of patients and employees that need to be tested. And then we uniquely also expanded testing to using platforms that can help target different populations. For example, the emergency department, kidney transplant patients, and so forth. University of California wide, we live in a world of 5 University of California health systems. So we span across California. You can see here we all scaled up nicely to meet the needs of the state. And at our institution, we ultimately landed on 3 domains of COVID testing during this early phase. We had our high throughput system. Any patient will be taken, asymptomatic, symptomatic. It's an offsite lab, does SARS-CoV-2 and eventually SARS-CoV-2 and flu, results in less than 24 hours. We were averaging about 12 hours throughout the entire pandemic, but we had to fill up those 96 well plates. We quickly realized that patient volume, sample volumes were variable. So we didn't always fill up 96 well plates. So we brought in a medium throughput platform to keep turnaround times not just fast, but consistent. And that's what our patient care providers needed, consistency in addition to timeliness. So we brought in a smaller platform that can do batches of 6 times 2, so 12 total, and it'd be able to turn out results pretty quickly. And we relied heavily on our existing capabilities of point-of-care molecular platforms, which later had SARS-CoV-2 and flu A/B testing capabilities. And we limited our medium throughput respiratory panel to COVID only in our core lab for transplant and urgent bed allocations. So our evolution of testing was quite interesting. So you can see here on the x-axis time from 2020 to 2021, and then on the y-axis, the trade-off between portability and throughput with these platforms. So our first open plate platform in 2020, February 2020, high throughput systems, medium throughput systems. We brought in sequencing to do variant surveillance. We even brought in antigen testing on mobile vans to be able to reach out to the migrant worker community in our region, so the California Central Valley. And of course, we leveraged, like I noted, our molecular point of care systems that we had prior to the pandemic, but was able to accelerate our testing capability once the SARS-CoV-2 assay was available for it. We brought in high throughput antigen testing to supplement our testing capabilities and also use for return to work screening. So as we moved through 2020, we became concerned about flu-vid, right? The potential for both COVID and influenza to hit us very hard. And so in November, we were looking very closely, should we start bringing in these now combined flu A/B SARS-CoV-2 tests? And we did. We deployed them pretty quickly on these 2 platforms. And we updated our education for the institution. So this is an example of some of the education we provided. If you're a patient who's in the ED, who needs rapid rule out for a bed, or need rapid rule out for a kidney, you have point of care molecular. Respiratory panel, we stuck with our original education pre-pandemic. Yes, we could detect a lot, but our primary concern at the time was SARS-CoV-2 and so forth. But we pretty much limited due to the capability of our point of care and our high throughput system. We actually didn't even do SARS-CoV-2 on the respiratory panel. We kept our original respiratory panel. So this was able to optimize our test utilization. And then we had send out options for sequencing, which was highly restricted for our infectious disease team. Flu-vid, of course, didn't pan out. You can see the red dotted lines right here. This is the prevalence percentage of influenza admissions. It was pretty much nothing. So nothing really occurred, and we continued to deal with COVID during the rest of the year. 2022, supply chains improved. We refined our testing capabilities and focused more on using our high throughput system and our point of care molecular. In fact, at one point, point of care molecular was doing close to 50% of our volumes for COVID, and these are now limited to predominantly inpatients, ED, and so forth. ED was doing quite a bit of testing. We had added inpatient obstetrics patients. And if you don't meet those criteria, you go to the big high throughput system out there. So this became a pretty good model for our clinicians to use. As we headed into 2022 and 2023, we actually see an increase in respiratory infections and, of course, admissions as well. So this is, again, California data. And you can see here, and this is for our region. And in this case, you see this increase of flu A/B, RSV, and so forth. And so as we continue on, our test utilization seems to work. Our education seems to work. Our respiratory panels weren't frequently used. We did see a surge in RSV, flu A/B, and other non-SARS-CoV-2 infections in the last year. But again, our ED did not utilize our respiratory panel, again, seeming to parallel our education, right? Test what you know you can detect, that you want to detect, and what you can treat. In patients, however, this past year, we did see an uptick in respiratory panels because for some reason they decided to want to cohort patients, right? RSV with RSV, parainfluenza with parainfluenza. And we had to educate them. What did you do before the pandemic, right? And so that helped with utilization. So we did some re-education there to calm people down and so forth. And we also educated people on these other viruses that existed before the pandemic, but you don't hear about as much. So in this case, this is a recent article that we published out there on human metapneumovirus, just to let people know what it is, and you can't do much with it. So don't worry about all the testing that we have to do. So this is where we landed post-COVID testing. And you can see here, we pretty much stayed mostly the same. We're now more refined. We still use our high throughput SARS-CoV-2 flu platform. We still have our rapid point of care molecular platform. And we're now going back to our respiratory panel, removed completely that medium throughput COVID test. And we're now back to where we kind of started off before the pandemic. And it seems to be working well in terms of test utilization and efficiency. So to close out, the COVID-19 pandemic resulted in an unprecedented acceleration and development, implementation of all these infectious disease tests that we have today. We started with open plate PCR, quickly switched to high throughput, and then we saw the emergence of point of care molecular platforms that can do COVID testing and even home testing kits. Multidisciplinary partnerships are key, and you'll hear about my colleague and friend, Dr. May, very shortly. So friendships, partnerships matter to be successful in implementing test utilization strategy, in this case for SARS-CoV-2. Sequencing was helpful. It was just told us when the next surge would be and what new variants may be out there, but clinically it didn't really help us too much. It did help with contact tracing, of course. And post-COVID emergency, testing was really refined. We had to pretty much land back where we were. We can't have a whole library of all these PCR platforms. We have to be more efficient and go back to where we were. And in this case, testing for clearing employees and, of course, our patients with COVID-19 infection. So with that said, I'm going to hand it off now to Dr. May, who will talk about the clinical impact of all these respiratory panels and so forth. Thank you.
Great. Thank you. Bear with me. Give me a moment to get the presentation going. So I'm going to shift gears a little bit and talk about clinical perspectives on rapid molecular testing in the emergency department specifically. I do have a few relevant disclosures related to diagnostics, including receiving honoraria and being on an advisory board for Roche. So I really want to bring us back to what is the purpose of all this diagnostic testing we're doing. Dr. Tran gave us a great overview that highlighted the implementation of diagnostic tests during the COVID-19 pandemic. But really the whole purpose, obviously for us practicing physicians in the emergency department and other settings, is that we need these diagnostic tests to help guide our clinical decision-making. And ultimately, in terms of infectious diseases, one of my other roles has been focusing on emergency department outpatient antibiotic stewardship. So we really want to reduce that unnecessary antibiotic use, which occurs most frequently in the outpatient setting by volume. 70 to 80% of unnecessary prescriptions are for presumed viral respiratory tract infections. So what we really want to move towards is a paradigm shift where we have more targeted treatment. Of course, the goal is to improve our patient outcomes and to reduce adverse events related to excessive antibiotic use. And then with that, hopefully a downstream public health benefit in terms of reducing the acceleration of emergence of antibiotic-resistant organisms. But we still, to this day, have a number of limitations we have to consider. So our clinical judgment for infectious diseases diagnosis is pretty insensitive. Patients with influenza present similarly to patients with COVID. There's a lot of overlap of symptoms. And unfortunately, many of the diagnostic tests we have to date don't provide quick and accurate data. And this leads to an overly conservative management approach, which generally means, at least for our patients that look a little bit sicker in the emergency department, starting broad spectrum antibiotics, which may be unnecessary, and certainly in the inpatient setting, often continuing those antibiotics. Of course, these benefits can be offset by the cost of the diagnostics and also any potential complications that patients may experience from unnecessary treatment. So what is the general clinical perspective on molecular testing? And we're really going to highlight here respiratory tract infections. So the reason that we do the testing is to provide information and education to patients on diagnosis and management. We also want to inform disposition decisions. So is this patient at risk of severe infection? What are their comorbidities? Is this patient likely to be admitted, or can they be considered for discharge? Certainly placement. We had a number of considerations during the COVID-19 pandemic where our nursing homes and assisted care facilities and skilled nursing facilities were not accepting patients until they could be documented as COVID-19 negative. And then, of course, as Dr. Tran highlighted, infection prevention purposes and cohorting, as well as preventing transmission within the hospital. We also, as I had alluded to, want to facilitate stewardship and then, frankly, also facilitate diagnostic stewardship by reducing ancillary testing and really considering which tests are really absolutely necessary for patient care in terms of, thinking about, is this test result going to actually impact what I do for the patient? And then I think, Dr. Tran did a good job of this, but we really need to define what we mean by multiplex. So are these syndromic multi-pathogen panels, with the 20 plus targets, or, we can also have multiplex testing, such as with the point of care testing in ED that look at really targeted panels that may have just 2 pathogens or 3 pathogens. And I think it's important to highlight because in the emergency department and other settings where we're treating patients who may be appropriate for outpatient discharge, we're really looking at this test to treat model that we used during COVID. But right now, there's really only a couple of viruses that we really can use for this test to treat model where that diagnostic test that's going to be positive is going to impact perhaps a treatment decision with a particular antiviral or with particular other therapeutics. And I think, for some pathogens, there's a lot of focus on RSV now due to the recently approved vaccine, but there may be some upcoming therapeutics that could also, in the near future, lead to a test to treat model for RSV. However, many of these other pathogens, such as human metapneumovirus or adenovirus, are sort of a nice to know, but there's really not much to do about it. And I think it's been difficult to show the value of simply providing that information to patients who may or may not understand the implications. And then finally, mobile health, urgent care at home, hospital at home. I think there's some interesting opportunities there for point of care as well as other rapid tests. I just wanted to highlight some work we did here at UC Davis Health looking at rapid multiplex testing for patients who were presenting with respiratory tract infections in the emergency department. So this was a randomized controlled trial where we enrolled 191 patients. 93 were randomized to the rapid molecular syndromic panel, and 98 received usual care directed by the treating physician. And we found that, not surprisingly, due to limitations in terms of what we can do at the point of care, 57% of our test patients and 7% of our control patients had actual virus detected. And then the graph on the right shows you the percentage of patients that received antibiotic treatment. You can see that it was 22% for the respiratory panel and 34% for our control patients. This was not statistically significant, but sort of trending towards that area. So you need to treat or to test large numbers of patients in order to actually see a difference. I think one of the challenges with this study is this study was implemented without the context of antibiotic stewardship. So essentially the test was turned on, patients were enrolled, the physicians were asked to enroll the patients, and essentially they still did what they were going to do. So I think in real practice, it's very important for implementation to consider antibiotic stewardship education and really that behavioral change that's needed to reduce inappropriate use. So I think there has been, in terms of rapid multiplex testing for the respiratory tract infections, at least, a trend toward reduced antibiotic use. In the literature, this magnitude is much greater in children than adults, presumably because most children are healthier than many adults that we see in the ED or that are admitted to the hospital. But essentially, we also did not see any differences in antiviral use, length of stay, or ED disposition. So there really needs to be future research looking at the clinical utility of these panels, and then the cost effectiveness versus more limited tests such as influenza and COVID. Because essentially, if you're going to implement these tests and then the clinicians are not going to actually use the results to direct care, what you're simply doing is adding cost of the visit without actually providing value. And I'm assuming most of you have either been in the ED or had family members in the ED, or have some familiarity with this setting. We're really struggling, particularly in the post-COVID pandemic, with high rates of ED crowding and boarding of inpatients due to lack of capacity. We have to see patients with a very rapid rate of patient turnover. And so decisions tend to need to be quick without a lot of information. We do struggle with diagnostic uncertainty. And while I think some of these point of care and rapid tests can help with that, there's still concern for poor outcomes. Even where a virus is identified, it may not impact that antibiotic prescription. And then we also serve as a safety net. So there's a lot of lack of patient follow-up and increasingly more concerns about Press Ganey scores and patient satisfaction. So I think despite all these challenges, there are some opportunities to implement rapid molecular diagnostic tests in these episodic acute care settings, such as the ED and urgent care. But we really need to think about doing that in a very strategic way. And it's not going to be a one-size-fits-all. It's really going to depend on your facility, your patient population, the resources that are available in the laboratory. And then, of course, appropriate integration into the clinical environment is absolutely key. I think too often we implement tests and don't think about workflow assessment. So, for example, we have the unique challenge here at UC Davis where our micro and molecular labs are off-site. If we're going to implement a rapid molecular test for, meningitis or respiratory or whatever it is, well, if that test is not run on demand, it can be very challenging to actually impact the care of the patient at the outset. So really needs to be aligned with clinical operations and with the consideration of the patient and patient outcomes at the center. Ideally, when we consider, particularly for point of care in the ED, and I'll extrapolate to the urgent care setting, for high risk conditions, certainly we want high sensitivity and specificity, and really any turnaround time that's more than 30 to 45 minutes in a patient that's not being admitted to the hospital is not generally of value to the ED, because often it's cheaper and quicker to just make a decision to treat. And so we really need to look at that, and also ease of use, I think, as well as fitting into the workflow. So I think remaining gaps for the future are, what are the best patient populations for this syndromic versus sort of a selective pathogen approach? And then what about host response? Think of things like UTI, where even if you diagnose bacteriuria, that doesn't mean the patient actually has an infection. So how do we incorporate the host response in our diagnostic testing? And then we also have some considerations as to whether it makes sense to do central testing, to do batch testing versus point of care. And I think that just depends on the clinical laboratory and the workflow considerations, workforce issues. Here in California, we implement point of care testing that needs to be run by a licensed professional. So this can be a burden on the nurses. And if it can be done just as fast, ideally the turnaround time, there's the instrument turnaround time, but there's also the real turnaround time, which is the time the clinician ordered the test to the time it actually results, can be significantly delayed even in point of care testing. Number of regulatory issues, and then of course this may be geographic, but I do also see many opportunities for mobile CLIA wave tests, or thinking outside the box. So there are a number of barriers. especially in our complex healthcare environments. And I think a lot of it, as I mentioned with the stewardship, is this failure to consider clinician behavior as a major piece. So it's not sufficient just to implement your diagnostic test or even just to provide some education. We really need to think about technological approaches and what does that mean for low resource settings. So this is just sort of these two distinct cognitive systems we have. We like to think that physicians are very, controlled and make effortful decisions, are rule-based, but the reality is in a busy ED environment, that's not always the case. We're more experience-based, fast, and these decisions are often made subconsciously. So these are my recommendations for multiplex syndromic testing. I think in the inpatient side, the intensive care unit, best if one can get a lower respiratory tract infection specimen, those who are immunocompromised or in high-risk units. And then in the ED, really probably most valuable for patients that are admitted or immune compromised, for example, post-bone marrow transplant patients, where there may actually be some treatment decisions that might be different or experimental. And then for pediatrics, due to the high prevalence of viral infections in those with respiratory infection, it makes sense for admitted patients. So this is otherwise, I think targeted testing is much more valuable in that test to treat model. So in summary, I think there's a tremendous opportunity for us to use these tests to target antibiotic use. We have some real public health implications, but still have a number of limitations to be addressed, including, the need for on-demand testing, whether it makes sense for these tests to be point of care or run in the lab, getting buy-in and behavior change from the clinicians and the patients as well. So I think we have a number of opportunities for future research and decision support tools and digital tools to support that reporting and treatment. And with that, I will stop sharing.
Thank you, Dr. Tran and Dr. May, for that lovely synopsis of what UC Davis is doing to address this issue. I now want to make a reminder that the audience is able to submit questions for our speakers using the Q&A function in the application. So please do that, and we will address those audience questions at the end. But now I'm going to switch over to our panelist discussion. First, starting with Dr. May. So what is the clinical impact that you all have experienced? Maybe talk a little bit about the before the pandemic and now today with the changes that have been made with the lab.
Yeah, and I can speak, I can't speak as much to the impact of, the syndromic multiplex panels because we really don't use them very, very often. So I think that's more of a discussion for the inpatient setting. But I feel that, implementation of point of care testing, initially in 2018 for influenza A and B and group A strep, I think it provides a pulse check on what's going on in the community in terms of respiratory infection surveillance. And then, where there's treatment, for those conditions and patients are at high risk, I do think it facilitates conversations with our patients. And we actually have shown reduced antibiotic prescribing for patients with pharyngitis in our ED and outpatient setting, just by having that test available. So I think it helps move us more towards diagnostic testing and targeted testing and treatment as part of the standard of care. So I feel we've had especially during COVID, we were able to use the rapid diagnostic test, not just to, guide disposition decisions and, educate patients and start appropriate therapy for those at risk. But I think, we also had an impact on being able to enroll patients into clinical trials for COVID-19. So I think that was another side benefit of having the point of care tests available.
That's great. Thank you. So how about I ask the same question to Dr. Tran? Can you speak a little bit about maybe the impact of syndromic testing with the lab, what the lab has seen and the clinical impact?
Yeah, I would have to agree with Dr. May, just because utilization is low, other than that surge this past year where folks were trying to cohort patients with like versus like. But I would probably say that it worked out for us in that we invested early in point of care molecular. So 2018, and it was already in regular practice at that point. So I think people became very trusting of the platform and also just expected that we're able to now handle the actual pandemic with these tests that are so fast. I would probably say in some ways our institution became slightly addicted to the rapid PCR test. Everyone wanted it. So it was a little bit of a hard sell for some, that they realized that supplies, at least during the early pandemic, was not abundant. But now post pandemic, I think the impact, I would say, is, again, people trust that the point of care device is just as good as the lab, and we're able to move patients through workflow a lot better. The respiratory panel, however, it never just gains much traction, just because for high deductible insured patients, it's exceptionally expensive for the outpatient. It's very discouraging. We don't want that either, and so we educate people heavily on that. But at the same time, we also realize that the vast majority of the organisms you detect on these syndromic panels, what are you going to do with it, right? And I think we've educated that well. So these smaller multiplex panels with 2, maybe 4 pathogens seem to be the sweet spot for everyday use, especially now in this post-pandemic world.
Awesome, thank you. And just as a follow-up to this question, you talked about how the syndromic panels, the clinicians wanted to order so many and they're ordering a lot. Like, what factors did you consider when placing those restrictions?
Well, I think for us, for some reason, first, I don't think it was a hard fight. Maybe Dr. May can push on it too. I think when we implemented the education, there were some people that kind of wanted it, but when they realized the overall cost, and then you ask them, what are you going to do with, a regular coronavirus? What are you going to do with an RSV at that time, right? I know RSV, there's perhaps treatments coming, but I think people kind of landed down, and during the era that we deployed this, folks became more cost conscious for the patients too, right? Again, going back to that example, it could be thousands of dollars for a respiratory panel with little to no benefit for an outpatient, right? Larissa, what do you think? I mean,
we received a number of complaints related to the syndromic multiplex panels. It's not as much of an issue if a patient's, we admit, we have pretty high rates of admissions in our quaternary facility. So about 30%, but for the other 70% of patients that are discharged, if one of these panels is ordered, and it's not covered by insurance, or the patient has a high deductible plan, patients are literally complaining about like bills that are thousands of dollars, for diagnostic testing that actually doesn't yield anything useful. So I think the value remains to be seen for these tests, and I think that's why, Palmetto and CMS have really, like pushed back on the use of these tests outside the ED setting, outside the infectious diseases setting. Really, we've spent a lot of work at UC Davis and our Diagnostic Stewardship Committee, really, mostly frankly scrutinizing these syndromic multiplex panels in the outpatient setting, because really it's like, it doesn't seem the value is there for most patients.
I see. Thank you. And I guess a follow-up to that too, what gaps have you identified within your diagnostic stewardship or your clinical team that needs to be addressed in order to at least maximize the impact of these syndromic multiplex panels and patient outcomes?
I think from the clinician standpoint, like better guidance as to which patients, really benefit from this. There's still limited studies. There's a lot of studies, sort of looking at diagnostic performance and workflows, but, the benefit, you've really got to test like hundreds and hundreds of patients and really have the clinicians like be using these tests to make decisions, which unfortunately I think they're not a lot of the time, because the argument always is, okay, I have this like immune suppressed patient or slightly immune suppressed patient, and I sent this panel and it popped up positive for, rhino enero. But what if the patient still has a bacterial infection, right? So it doesn't completely solve the issue. And I think, and it just becomes very expensive. And so I think we actually do need to put some hard guardrails. It probably has to start, with a good collaboration between the clinicians in the lab. But really, we're very interested in test utilization and making sure it makes sense. So I think we've worked pretty well together to, and I think we have from an informatics standpoint, these panels that are specific to the ED for respiratory infection testing. And that's been, I think, very helpful for the clinicians, because nobody wants in the moment to be worrying about which test should I be ordering in what scenario.
See, that's great. And I think this is a nice segue to my next question in discussing the partnership between the lab and the clinician. How about Dr. May? Can you touch a little bit on how you partner with the lab in terms of either bringing on the new test or after the test is implemented, how to ensure diagnostic stewardship is at play here?
I think in terms of infectious diseases, we're very fortunate here because our teams are actually very integrated. So, I've been a long time collaborator of Dr. Tran's, both from a research standpoint, a clinical standpoint. It's not just true for infectious diseases testing. We have other partnerships for diagnostic testing, but I think it's those relationships and really a willingness to kind of collaborate together and take everyone's input that, and share our expertise. Because the ED doesn't typically, I may be the associate director for microbiology, but most ED physicians don't know the nuances of like little tests. And so I think it's having trust and a good relationship between the lab and the clinicians to really make that work, frankly. It's unfortunately it's not the case at at every place, but as much as there can be an ongoing dialogue and we have it, we have way too many committees, right, in healthcare, but we do have some committees where we come together in a very logical fashion. So we have our antibiotic stewardship team, our planning committee. I sit on that committee as an ED physician, and we have a great relationship with the micro and molecular labs in that setting to think about all these issues. So I think having that open dialogue, and then I think it also helps to sort of have the perspective of the whole health system. I think our funds flow model has helped a little bit with this. Perhaps it's like, what is the value to the whole health system? It's not just the micro budget or the ED patient like reimbursement. It's sort of thinking about it more holistically in terms of what makes sense.
Great. Dr. Tran, do you have anything to add or provide your perspective on the collaboration between the lab and clinicians?
Yeah, I think it's important for laboratorians to have their face out there and reach out. So it's not just being called to the committee or just talking with some folks on the bedside from time to time. I think what has helped us at UC Davis is being proactive in just putting our face out there, right? I know the ED director has a direct line to us, and he knows that if he emails me even in the middle of the night, he probably is getting a response back pretty quickly, right? So and we'll be able to work on something. And sometimes the things may be harder to fix, but I think that has helped us build that relationship and that trust that Dr. May mentioned, because I think when we deployed our testing during the early pandemic, there was a lot of discussion on another point of care molecular platform, which we already did a lot of work investigating prior to COVID. It wasn't as sensitive as we would like since it was not using RT-PCR, right? It was using isothermal methods. In our case, the institutions, once they saw on the news, this thing has come out to be a point of care molecular test, and everyone said, we want that. And I raised my hand and said, hey, we want to wait a little bit longer for a more sensitive platform. We already have this current platform. It's going to come out soon. And guess what? Our hospital, our health system, both the ED, inpatient services, and leadership trusted us. And of course, as you saw, we implemented the platform we preferred, which we already had, and it was used to great effect. And guess what? Other facilities that use that isothermal method, there was a lot of media coverage of how it was not sensitive enough later. Supply chains were affected. So we've done very well in terms of building that trust, keeping that trust, and then and perpetuating it, and of course showing the data of how well we affect it. So it's not just about bringing something live. We work with Dr. May and other groups to not just deploy something, but show that we had this measurable impact, right? Because we have to prove our value to the system as part of the healthcare team.
I think that was a really great example of what lab clinician partnerships and stewardship looks like. Are there any other challenges, even outside of respiratory testing, that this partnership is currently tackling or recently tackled, either through the partnership or the Diagnostic Stewardship Committee?
No, procalcitonin, right, Larissa? We did procalcitonin recently. That was through the pandemic. When we're working through, in the infectious disease domain, we're working with our OB-GYN team for HPV being a primary screen. So we're looking at that. We're bringing in sequencing, and our Dr. May and our ID chief are working on that with our micro team. So it's endless, right? We just have a long list, a laundry list of things to do in not just the infectious disease space, but I think we're very lucky to have all these clinicians willing to play some part in the process. They may not want to be doing the physical validation of the test, right? But their input is so valuable, right? We like that buy-in early. We do our best to achieve that. Larissa, I think I hit the big ones, but yeah.
No, I think one of the still remaining challenges without an easy solution is, we really need more solutions, closer to the patients. So not necessarily like point of care, but like close enough to the patients, so that if we have a test that needs to be or should be run on demand, that's actually going to impact clinical decision making. If having a courier pick it up, take it like across, then batch the test results in the molecular lab, I think that that's probably not the best intended use for some of these tests. So I think these are ongoing challenges and discussions we have, is how can we ultimately try to bring these testing modalities that are needed closer to the point of care. And as new technologies become available, I'm sure we'll have additional discussions, but I can specifically say for meningitis and encephalitis, we did try to look at our data, and unfortunately, because there were no guardrails around ordering the test, and because the test was not turning around in less than at least 8 to 12 hours, really not able to demonstrate any benefit to ordering the test. And so then what happens is it just drives up cost without impacting clinical outcomes. And that's really what we want to try to avoid. And I think our diagnostic stewardship committee is very focused on that and trying to really figure out where the biggest bang for the buck is with these tests, given the constraints, of having to have some of these tests that are not next to the patient.
Sure. What are some metrics that you all measure or look at when determining that bang for your buck? Or does the leadership team ask for metrics?
I think leadership teams for us in the lab, they do ask for metrics. I mean, for us, we at least provide our metrics of something we're working on quality-wise annually at minimum. We have used our point-of-care molecular platform a couple of times when we implemented flu, AB, Strep A originally, right? And so the metrics we used, for example, obviously turnaround time, that's an easy one, right? We went from a lab-based system to point of care. Point of care is going to be faster. Cost per test, especially for outpatients rather than an inpatient charge for a DRG. How many billables we're generating, right? So there's the revenue side, so the finance people will be happy. The harder ones, but we still executed. In fact, we just had a paper finally published, right, to show the clinical impact, right? So that's the one where it requires a little bit more energy to grease the wheels, but to collect the data to see how we improved either antibiotic stewardship, a treatment with antivirals, say in the case for influenza, list goes on. Those are harder to capture, but we still do it, right? And for us as an academic institution, it produces a publication, which is nice to share with people. But those are the common metrics that we can more easily obtain, right? Because other ones we can pull but the deeper dives into the chart review, those are a little bit harder to do. We haven't not done it. I think we've done a few of those, but yeah, Larissa, don't you think those are the common metrics? But there are others that we go deeper into.
I mean, certainly the things that the ED has a similar system, the things that we're beholden to are, we want to reduce our left without being seen and our length of stay in the ED and, anything that can like help with throughput, to take care of more patients since our capacity is so severely constrained is helpful. I did mention there are some challenges, if I have a patient, I can say that before COVID-19, not every patient presenting to the ED with respiratory symptoms was getting a diagnostic test. Now everyone is. So every single patient. And it's partly, like a change in, mentality around, like testing, but it's also, I think, patient demand. And so now every single patient is getting, a COVID flu test at least. And I think it's challenging because, as we go into the respiratory season and, starting to worry about RSV also, having these point of care tests and having the nurses who are, burdened with other tasks, also having to collect the specimen and then run the specimen, really we see when we get busy, our turnaround times for point of care testing, again, effective turnaround time can be like an hour. So sometimes you wonder, is it just faster to collect a specimen and send it to the lab? It might be, depending. I mean, part of it is the time to collect the specimen, but I think there are still some challenges in terms of workflow. And so that's why I say there's not a one size fits all approach. Sometimes point of care makes sense. Sometimes it doesn't make sense.
Great. And that brings me to my next question in terms of the impact of multiplex testing and co-circulation of viruses. What do you think the future is of multiplex testing for respiratory disease?
Well, the future, I'm biased. I'm the clinical chemist in the room, right? The future is, the goal is, if some smarter person than I am out there can make a test that can, they can detect 20, 30 or whatever, pick your number of organisms, but I don't have to pay for all 20 if I don't need all 20, right? In clinical chemistry, I could do a basic metabolic panel with 7 things. I could pick one thing, I could pick 2, 3, or any combinations all the way up to 7, right? And it will be billed accordingly for that. So I think that's one aspect, because right now it's an all or nothing game. And majority of the time, as we kind of alluded to, most of the pathogens on these syndromic panels, they might be nice to know, but typically don't have much meaning on what you can do with it, right? So I think that's one aspect, and that's probably one area from an analytic perspective from my end.
Yeah, no, I think that's true. I mean, oftentimes clinicians don't really know what they're looking for, but I think it would be important to have these smaller panels which just have the pathogens that really matter, or even if there was just, and I think there are some opportunities like this, in terms of reimbursement, if you could order the first set and then test for the others, but don't pay for it unless you need to reflex to the others. And I think obviously for patients that are admitted or critically ill, it does perhaps make sense to know what the pathogen is, even if there may not be targeted treatment, because it does provide useful clinical information. But I think for the run of the mill, urgent care, I've got a respiratory infection, I want to know if I have COVID or flu, I think it makes more sense to follow that test to treat model, really, to be efficient, and to not continue to make things more expensive in healthcare. So I think there's the test at home also. I think patients with COVID definitely have learned I can take charge of my my own health, and I can test for these conditions. And and I think we can use telehealth and other innovative models to provide treatment. I think it would be great if we could just everyone could think outside the box. And I'm really interested in industry academic partnerships or industry healthcare partnerships, that there's a way to sort of just to do that, or to have that model.
So besides near patient test to treat, is there anything else on your respiratory wish list, Dr. May? And I'll ask the same question to Dr. Tran.
I mean, to be honest with you, I still think, what I would love to see in the ED is patient self-swab, and then just an easy test that takes 5 minutes to run. But that's sort of my pipe dream. And then I think, for sicker patients, obviously we need more accurate information. So how to identify someone with sepsis, so from a respiratory infection, right? If we identify, and then the host response piece, I think, is also important, because, just because you detect rhinovirus doesn't mean the patient has an active infection with rhinovirus. They kind of stick around. So, I'd like to see more value from these tests. So I think that's my big ask, and also decreased cost, or at least less seeing it as a cash cow for the systems to overcharge patients and create a lot of discontent.
Right. And Dr. Tran, besides the flexible ordering, what is your wish list for respiratory testing?
I think we need to start looking towards the future, and I've been told that 2023 is the year of AI, right? So artificial intelligence, I think, will probably play a role to help guide both patients and providers on what is the optimal way to test. I think so for AI to work in any profession, we need very clean data. So my wish list would be, I think we need cleaner data from our electronic health record and laboratory information system, so that we can leverage that data to really drive the best use of all tests, in this case, respiratory testing, right? Imagine a world where AI tells us that we now have populations that are predicted to benefit from detecting X, Y, and Z. So we target those populations for that. So we will optimally make the best use of perhaps expensive tests, but the value that we gain back from that would overcome those costs. So I'm thinking perhaps too far in the future, but what we've seen in the last couple of months with AI, things are moving fast. So
Thank you for that. I'll keep those topics on my radar too. So before I switch over to the audience questions, we have quite a few coming through. I just wanted to get, if you can tell us how you're preparing for this upcoming respiratory season, even though we're right at the start of it, maybe already in it in some states.
I'll have to say that not much has changed other than checking, our stockpiles of kits and then working through any emergency use authorized test conversions to FDA approved tests. Those are trickling in as we go through our list of platforms. Many of the platforms we have are already revalidated, re-verified, following FDA 510(k) approval for them. But I don't think there's much change in our operations other than, continuing the education, reminding people on the test utilization practice, which we've been encouraging for the last several years. So not much has changed other than just keeping an eye on the rates of positivity for these other organisms we haven't seen in a couple of years.
Yeah, I think from a clinician standpoint, we're just carefully watching what's happening, in the East Coast and other places. We're expecting RSV to hit, but RSV tends to be less predictable. So I think we're still talking about the triple-demic, but not quite sure, exactly what's going to happen. So we're just watching.
Great. All right. So with the last few minutes of our webinar today, I would like to open it up and now ask the audience questions that have been submitted. So for the first one, Dr. May, do you think there is a benefit to using a 4-plex test with COVID, flu, and RSV before a full multiplex syndromic panel?
I mean, I think for the vast majority of patients, that makes sense as a strategy and maybe the only strategy. And then I guess the question is, if you have a patient who's admitted or who is immunosuppressed, what's the benefit there? I think it probably does make sense to use the smaller plex panel, but then if that's negative, maybe reflex to a larger panel, but only for those patients, that are severely immunosuppressed or, are sick in the ICU with a respiratory infection.
Dr. Tran, do you have a laboratory perspective on that testing idea?
I would agree with what Dr. May says. I think where we run into some complex, more so reimbursement / IT issues is where, let's say the 4-plex test does flu, COVID, flu AB, COVID, and RSV, and then you reflex to the next panel, which is a larger, say 6-plex, 10-plex, 20-plex panel. We still have the same organisms on that panel. So we can't bill for the same bug, same test again, right? So we run into those complexities. So I think the challenges we face, it's something that we can overcome. We just suppress the other results and we only get paid for what we actually do. But the challenge is that we still live in this world where there's still a lot of overlapping panels and it is not efficient, right? So I think that's why I keep going back to thinking in my simple clinical chemistry mind, why can't we have a way to pick and choose what we want and be able to go back and not have to redo a whole new panel and not get paid for it, right? That's the challenges we're running into now.
And maybe it's, except maybe for infectious diseases clinicians, but I think the run-of-the-mill end user, the primary care folks, the urgent care folks, the ED folks, don't really want to think about it. So maybe just have those panels those are the pathogens that actually, have a treatment to pair with them, to pair with a positive. I mean, that's what I would say. And then, additional pathogens can be added as we develop and have therapeutics available for them.
Great, thank you. And this next question is for Dr. Tran. So it was mentioned that there was a preference for PCR testing versus isothermal. What is the difference with those two technologies, especially as the isothermal platforms are becoming more popular for point of care?
Yep. They are both good at what they do, but you just have to be mindful of their potential limitations, right? Isothermal is typically going to be faster, simpler, more cost effective, right? You don't have to worry about thermocycling, but oftentimes there are some price you pay and perhaps a little bit of sensitivity, specificity. Some types of isothermal methods also limit how easily you can do multiplexing. So that can also complicate things too. real-time methods of tried and true, right? Kerry Mullis invented original PCR. Of course, that's in the 80s. So we've had a lot of mileage on that and learned a lot about it. And PCR in general often carries with it a higher sensitivity and specificity, and people know how to multiplex well on those platforms. But I think the thing, and going back to what Dr. May commented on too, is how do we increase access to care for people and so forth? Chances are these isothermal methods are going to be the pathway to achieve that, right? We now live in a time where we do accept the sensitivity, specificity, compromise of antigen testing because they're cheaper. We can have more access to it. And I think the same will apply with isothermal testing. There are situations where isothermal testing is perfectly fine, just depending on what you're looking for, but you just have to know the limitations, right? This could be talking the difference between a 95% sensitivity versus a 99% sensitivity. 95 isn't something to scoff at, right? It's pretty good, but you have to know the limitations. And I think that's where education is key.
Awesome. Thank you so much. I think we have time maybe for one more question, and this is directed at Dr. May. What is the clinical impact or actionability for RSV in patients over 5 years old?
That's a great question. And I think my answer will probably change as you know, I suspect we will have therapeutics available in the next couple of years. So it will be a different, but I think, you know, just anecdotally at the beginning of the pandemic, before we really had COVID-19 testing available, we had a brief period where we were doing multiplex testing to try to rule out other organisms. At the time, it was thought that co-infection with SARS-CoV-2 and other viruses wasn't that common. You know, I think that may have changed over time, but we started noticing a lot of, you know, relatively sick patients, you know, elderly patients or adult patients with comorbidities who have RSV. I do think, you know, even in the under fives, my pediatric ED colleagues will tell me that they don't really care about RSV because there's no treatment except for those, you know, significantly at risk. And that bronchiolitis is just supportive care. So I think it's even debatable in those under 5, other than it may give you some important information as to progression to give the parents, because RSV typically tends to get worse as you get, you know, further along before it gets better. And so I think that is useful information in the pediatric setting. But I agree, there's not that much value. I would say I know in our post bone marrow transplant, severely compromised individuals, they will sometimes use ribavirin. So that may be one category where we would recommend RSV testing. But I think in the clinic setting, probably doesn't make a lot of sense past, you know, that early age group.
Thank you, Dr. May. And we've now reached the time of the end time of the webinar. I'm so sorry I couldn't get to all the audience questions, and there were a lot of really great questions. So I'm going to turn it right back to Jenny to close